Um, so yeah, again, welcome to the response rally. We have about 5 weeks left in our NPRP assessment, and so we just want to spend a few minutes talking about some strategies and some things that can be done to help encourage folks to get their responses in, and we'll go from there. And Jane's actually gonna handle most of the tech talk today, and then I'll jump in for a couple of minutes at the end. But if again, as always, if you have any questions, feel free to put them into the chat or mention them, and we'll do what we can to answer them. But go ahead and turn the time over to Jane. Can't hear you, Jane, if you're talking.
Sorry about that. Thanks so much,
There you
Rick.
go.
Today we're just going to do a quick review of what monitoring looks like in Tableau. These dashboards can really help you to boost your state's response rate and update plans. We're also going to discuss some techniques to encourage non-responding hospitals to complete the NPRP assessment. And we want to hear from you. We want to hear some of your success strategies that you've been using. Things like, social media or networking or meeting site visits, anything that you can think of that has been useful and working in your states, we'd love to hear about. You can put those things in the chat, or you can wait until we get to that point in the discussion. And then we're excited to have our EDC Director, Melissa Laws, and our NPRP co-lead, Dr. Hillary Hughes, is going to be with us for a little bit today. They can help answer questions along with others at the EDC that you might have about the assessment. So we'll go from there. So where are we? We're actually a little more than halfway there. By time frame, we're about 7 weeks into the data collection with about 5-ish weeks left. And our last update showed a 43.8% response rate nationally, and we're still climbing. We're super excited about that. Considering that each state has had some unique challenges, this trajectory is still trending about 7% higher than response in 2021 at about the same point in time in the data collection. So certainly awareness of the project and previous participation has helped. But cannot thank each of you enough for your hard work and all that you have put into the NPRP assessment in your states with education, promotion, monitoring, follow-up support with your emergency departments, and so many things that we aren't even aware of that we know you are just fantastic at making connections. Your efforts really are making a difference, and we truly appreciate it. We are all working toward having a large number of emergency departments participate in the NPRP assessment so that all hospital types are represented. Everything from rural and critical access, freestanding EDs, IHS and tribal, general and children's hospitals need participation so that we can have an accurate picture of pediatric readiness. Pediatric configuration and trauma center designation are also considerations. And we especially want to include sites that have never participated in the assessment. This is an important group. A large response also helps us to reduce non-response bias. It increases the validity and reliability of the data. And a high response also shows a comprehensive, accurate overview. It shows pediatric readiness impact and the value of the program itself and the projects that we're all working on. Our data manager, Patty Schmuel, did a fantastic job at an earlier Tech Talk this year describing the 2026 NPRP state response rate report. So I'm not going to go over these in too much detail. Most of what you have been actively checking, or most of you have been actively checking your responding and non-responding EDs, as well as those that have participated or new sites. And your county maps have likely changed over the past few weeks. So these dashboards are updated frequently, about every hour or so. So keep checking. What you see kind of on your slide here is national data. And much of this information is also captured on the public dashboard from the pedsready.org site. This is just kind of a reminder that when you are in your respondent list, you're going to see your response rate comparing 2021 and 2026. You can also click on the national response rate that will link to the public map. Your state response rate is also shown by percentage in addition to your numerator over the denominator. Again, the numerator is the number of hospitals you have listed in CLEMS. I'm sorry, the numerator is the number that has participated already, and the denominator is the number of sites that you have listed in CLEMS. So on the right, just as a reminder, you can sort by ascending or descending there. And then you can also sort by state name, hospital name, county, hospital region, and date completed. So just keep checking each of these dashboards. You know, the non-respondent tab will show you your non-respondent to respondent ratio, for example. So there's some different things on here that are good to kind of help you get a big picture of what's going on in your state. If you want to follow along in Tableau, I'm going to spend a fair amount of time just on the incompletes CLEMS report. This is also a great way to monitor activity in your state. So if you want to go there now and sign into Tableau, I'm going to have Andrea put the link in the chat for you for convenience. And this report shows you emergency departments that have said no to the 24/7 question. It helps you to check all of your incompletes. And it helps you to identify quick wins or hospitals that are really close to completing the assessment. It also gives you a high-level bailout summary and CLEMS differences so that you can update CLEMS as needed. And this is important as we go along in the data collection period because we don't want to have people not be able to find themselves, you know, on the PeaceReady.org site or have information that's not correct in there. So I'm going to go over these, like I said, in a little bit more detail. From here forward, I'm also going to mention that this data is not live. It's been de-identified and combined with fake data for demonstration purposes, so you might see some fun names of things in there. But below is the header that tells you that we're looking at hospitals that answered no to 24/7 below kind of the highlighted area here you see in red. The area you see highlighted in red is actually showing you quick links. So if you click on any one of these buttons up here, it will take you directly to that page. So this is kind of a nice home page. And then below you kind of see instructions that show you what you're supposed to do for this page. So on the assessment, it asks, does your ED, is your ED open 24/7? The criteria for inclusion in the assessment is that they must be open 24/7, 365. So if they say no to this question, sometimes they do that in error, sometimes it's an accident. If that happens, just contact your EDC TA. This is rare, but we do want the hospital to have a chance to participate and get a gap report. So we can reset it if that's the case. If the response was an error, you're going to want to remove that site from CLEMS. If they're truly not open 24/7, they don't qualify to take the assessment, and we don't want to add that record to your denominator if they don't qualify to take the assessment. So just be aware of that. You can see the tabs located up at the top that help you to know where you are. This tab is for all incompletes or where emergency departments are bailing out or leaving the assessment. So this can really help you to identify patterns if EDs are bailing out at the same question. If you are connecting with these hospitals for follow-up, for example, it's also useful to help you answer any questions they may have kind of ahead of time. You can prepare a response. So for example, you could say, hey, I noticed you started the assessment and haven't come back to it. Can I help you clarify anything? In this section below, you can see from left to right the column headings that start with portal ID, state, county name, hospital name, the day of the last time in the assessment that they were there. So this participant was there in March, and they bailed out at question 37. These are emergency departments after all, so it could have been for a variety of reasons. Maybe they needed to go help a patient, you know, maybe an emergency came in, or maybe they're just double checking with their leadership to see what they would like, you know, how they would like to answer that question. Then to the right, you have the bailout point. That's the question number. The question was it required? The answer to that was yes. and then the domain they were in. So they're kind of in the domain where they're looking at the providers who staff the ED, and then the actual question. And this is a policy question. So you can look at the question, have kind of a good overview of who the respondent was, and that can help you in outreach or just to kind of identify where someone might be bailing out. The quick wins tab is where you're going to see folks who are really, really close to completing the assessment. They might just be a couple of non-required questions away, or just not have clicked on the finish button. You'd be surprised at how often that happens, where people get all the way to the end, they spend all that time, and then they'll reach out to Peace Ready Support and say, "Where's my gap report?" And we look and say, "Oh, could you please just click on that finish button?" Sometimes people do like to go back though and make sure they answered all of the questions the way they wanted, or are waiting on some final information from an ED leadership. We strongly recommend you do reach out to EDs that are listed on this page and encourage them to complete the assessment. If an emergency department did not use the save and exit feature, they might just be wondering how they can return to the assessment. And you can have them try to go back to pedsready.org. If you have them get on the same computer and the same browser, they can reselect their name and information from the drop-down menus. Some people are tasked with entering in multiple assessments for different sites. And we just wanted to caution that if they are using the same computer to do this, it can cause issues with incompletes. It's really important to start and finish an assessment before starting another to avoid problems. So please make folks aware of that if you come across them. And as you can see again below, one of our favorite fictitious respondents started the assessment in March and got all the way to question 152, which is just an estimate of pediatric patients in the emergency department. So really, really close. Might be worth reaching out to see if Dr. Robbie will complete it. But remember that participants will not see their gap report until they click on that finish button. This is incomplete by domain. Or a high-level overview of the domain or section where most EDs are bailing out of the assessment. And I hope you can see that bottom portion on your screen. I was trying to give several examples here. You can see that on the left-hand side, the total section or total per section, the domain name is the second column, question bailout point, number of incompletes, and the actual assessment question is there. So the total column on the left, you can see that 219 people bailed out on question number one. And number one is just your name. These are people that basically just wanted to take a peek at the assessment before actually filling out their answers. And this happens a lot. So that number is usually pretty high. If you look down at the row below, you can see that 62 people bailed out on question 35. And two are still kind of stuck there on that question, but that's okay. Others below stopped at the quality and performance improvement domain. And notice that, sometimes it's not always confusion that makes someone be like one step away. Again, there's a variety of reasons that people, bail out at certain points. But if they are bailing out repeatedly at the same point, you can check the frequently asked questions page on the pediatricreadiness.org website for more information, or you can reach out to our Peds Ready support team if you have questions. So feel free to do that, ask questions, reach out to your TA. We're here to help you kind of clarify any one of these things here.
Jane, I'm
Uh-huh.
sorry to interrupt you. If you can go back, that's actually um, not correct,
Oh,
that
okay.
explanation. So the 219 means that entire section.
Oh, that entire section.
So questions 1 through 27 have 219 people.
Oh, thank you so much for
And
clarifying.
then question 1, you can see bailout point question 1. The number of incompletes for question 1 is 1.
Okay, thank you so much for that clarification. I appreciate
It's
that.
not 219 for the name. Yeah.
True, very true. Thank you so much. I really, really appreciate that. I missed the section piece of that column. I apologize. So grateful we have our data manager online to keep me in check here. Thank you so much. 219 per section. Questions 1 through 27, you can see question 34 through 39 in the row below, and then question 50 through 55. All right. The last tab that we're looking at here are cleanse differences. And this is a really important thing to go over. EDs whose very basic demographic information is different in cleanse than what was reported on the assessment. So this is what you have in your record versus what the respondent said on the assessment. And the higher the number in red below, the more differences exist between agency name, address, city, and zip. So the differences are shown in orange, and the same information and same meaning, they both concurred with each other, is in blue. So if you see something in blue, then you know that the cleanse information and the respondent information are the same. You're going to want to review emergency departments with a high number of issues. The data is pre-sorted from highest number of issues to lowest, with 4 being the highest. And if you notice that an agency has accidentally taken a survey under another emergency department's name, you need to contact your TA. This is really important because we don't want someone taking it for the wrong hospital, and then that hospital doesn't have the opportunity to respond for themselves. So again, just contact your EDC TA if you see that happening. If you see that an ED name is changed or their address in cleanse is correct, it could be that they took it for the wrong hospital, but it could also be that they are doing business as a new name. It could be that they merged with someone else. It could be for a variety of reasons. So I'm just going to take just a quick closer look at these. You can see that Dr. Abbott has put in the We Care Medical Center, but in Clems, we have We Care for Kids Hospital. This might be a simple name change. It could be a different hospital. You definitely want to look into that. If you look to the right on the address column, you can see that the street names are pretty much the same. Street and street are pretty much the same, whether it's an abbreviation or spelled out right there. You can see in the column for city that in Clems, we have Santos for the city, and for the respondent information, they put in Langdon. 2 very different cities. Would really want to check that out. And then the zip codes are also different. So just be aware of that there are some subtleties there, but some important changes that could need to be made. You also see in this row, we've got Nurse Evans that, said that the hospital name was ED, or in Clems, we have ED Drama Community Hospital, and the respondent information, she put Noah Wiley Regional Hospital. So very different names there, different addresses. The city name is spelled similarly, and then the zip code is exactly the same. So these are things that you're going to want to be able to check out. All right, so how can we rally more support from our emergency departments? We know that ENA and ACEP, AAP, ACSCOT, they've all been very wonderful supporters of the NPRP project and the assessment. Your ENA state chapters, we meet with them frequently, and they are their national leadership, and they say the chapters are just so excited to help the EMSC program. So if you have not yet reached out to your ENA state chapter and you need some support, please reach out to them. And we have Andrea put all of these links in the chat that I described here. Same thing with your ACEP state chapters. Really just want to help emergency departments get to that finish line with taking the assessment during the national period. We do have an ACEP webinar coming up on May 6th at 2 p.m. Central. And the link will be in the chat there as well for that. And then if you still want phone calling assistance, the EDC does have resources still available. So that link will also come in the chat. I'm going to have Braden go ahead and take it over and talk a little bit more about phone calls.
Thanks, Jane. So this will likely be a review for some of you folks who were here last month, but phone calling is a critical piece to the puzzle, so we just wanted to review it really quick. It'll only take just a couple of minutes, and then we'll open it up for some questions. So as you all know, the hospital contacts thus far have received a lot of emails over the last 8 or so weeks, like six emails per hospital. So for these final like 5 weeks, it is valuable to change our communication tactic to making individual phone calls to non-respondents. And that's an important thing to do because changing that tactic and changing that style allows us to reach people that maybe we weren't reaching via email. Next slide, Jane. So making those phone calls is admittedly a little bit labor intensive. It's a lot harder to make 10 phone calls than it is to send 10 emails. But the additional method of contact is a critical step. So the fact of the matter is that some contacts simply respond better to phone calls. And we found that some hospitals also have very strict firewalls on their emails, and they end up blocking a lot of outside emails, even from totally legitimate sources. Um, their firewalls just they like lean on a block first type strategy rather than an allow it if it's question or if they don't know exactly who it's from or something. And so there are some folks who just don't get the emails that we've been sending like we would think that they do. Um, and then the last thing is that making phone calls actually works. So during the 2024 PPRP assessment, that was the EMS and Fire Rescue Agency um, assessment that we did in 2024, nearly 40% of the total responses that we received came in during those last 5 and 6 weeks after we started making phone calls. And frankly, we hope to beat that number this year. We hope to get more like 50% or 60% of our total response to get up to that as high of a response rate as we possibly can. So it does work. You know, we really boosted, we as in the whole team, the whole EMSC team really boosted the 2024 PPRP response numbers after or due to making those phone calls. Next slide, Jane. The good news with that is while it is labor intensive, you can request help making phone calls. Like Jane mentioned, obviously you can solicit support and help from folks within your state program and others that that help you out. But also you can request the EDC's help in making those phone calls. By no means are you required to, but if that's something that you find would be useful in your state, the EDC can help make some of those phone calls in your state. Next slide. There are a couple of details if the EDC does help or if you would like us to help. First off, you have to fill out an online request form, which Audrey will drop in the chat for you. It's just a simple little form that you fill out that basically gives us permission to contact hospitals in your state. We generally aren't ever going to reach out proactively to a hospital in your state without your permission. So that's basically just gives us that permission. The help is obviously going to be based on EDC bandwidth. If we have 10,000 calls to make, which obviously that's just hyperbole, but we would only be able to get through so many. But as we currently are looking at it, we should be able to get through the calls that we've already been requested to make. So we do have some bandwidth, and if you would like help, please feel free to request that. And then the last little detail is if you do request help, the way that it works is basically we will split the list 50-50 with you. Essentially, we will be responsible for calling 50% of your non-respondents, and then you're responsible for either calling or drumming up support with your team or whatever the case might be to call that other 50% of your list. Next slide. So one thing that's what we have to say about making phone calls, and obviously if you have questions, feel free to ask them. But now, just as we get ready to finish up, we did want to open it up to everybody for just a minute and ask for, or I guess provide an opportunity for you to share with the team and with the group what is going well. Whether it's social media posts, whether it's talking and encouraging responses at conferences and meetings, whether you're visiting hospitals, things like that. Does anybody have anything they'd like to share about some stuff that you've done that has been successful with the goal of helping provide ideas and stuff to everybody else? And we'll just open it up for just a minute.
Hi, this is Candace Kefauver from California. I had put this in the chat,
Oh,
but I
nice.
just wanted to share some of our effective techniques for California. We formed a NPRP work group, and they've been reaching out directly to the hospitals. And then also here in California, we have a two-tiered system that oversees hospitals. So to that effect, we've reached out to what we call our local EMS agencies that oversee each hospital in their jurisdictions. And we've reached out to them to encourage the hospitals to complete the survey as well.
That's great. Thanks for that. Yeah, I definitely, as much as possible, and depending on the structure of the programs and stuff in your state, I'm reaching out to all those folks, whether it's regional representatives or whatever the case might be, is definitely something that sounds like is working in California, and I know that has worked in other states as well. Any other thoughts or anything? Andrea, go ahead.
I can't see if Greg's here from North Carolina. I don't think he is, but he shared an idea with me because I was helping him make
He is.
his calls. Oh, he
He's
is here?
waving. Yeah. Anyway, sorry, go ahead.
Greg, would you share like the strategy you were using?
Yeah, yeah, sure. I'd be happy to. So, in North Carolina, and everybody is unique and different in their own way, but here we have multiple different large hospital systems. So each system owns maybe 3 or 4 hospitals, or they may own 19 hospitals, or so far. I think that's the highest number. What I chose to do was align myself with a representative from each one of the systems. And each week, I email them their unique email list of non respondents to say, this is I put in a little chart. This is where North Carolina is and our response rate. This is the national response rate. And these are your problem children that have yet to complete the NPRP, and then that one person responds back to me, and they often email someone else that they've designated as the point person. And in a few situations, I know that that point person has gone ahead and set up office time with each one of their tertiary facilities to sit with them and fill out the NPRP together. So they still look like a non-respondent, but they remind me each week, hey, thanks for keeping us honest, but I've got these hospitals on this date and these hospitals coming on that date. So we're on it. We just haven't done it yet. So that's a really great approach, and I praise that. And I have great relationships with them. They know that I'm just sending these weekly emails out no matter what. So they know I'm not hounding them for nothing. That takes care of roughly half of the hospitals in the state. The other cohort of kind of non-affiliated hospitals are all on me. And then I have office staff within OEMS that has been helping me make phone calls. Some of those hospitals went ahead and did their assessment. So that really decreased the number of hospitals I really have to actually call, which I'm doing. I'm doing today. And I will say that every single one of the phone calls I've made has been well received, and the people were excited about the opportunity to do it. So no real big ugly pushbacks, and that's been my strategy in my state.
That's awesome. Thank you, Greg. Go
Braden,
ahead,
just
Andrea.
from the chat area, Dwayne agrees and is following a similar type of strategy and says it is the best practice. So those who are using it sound like are finding it very effective.
Great. We've got about 1 minute left. If anybody has any quick questions about this or anything else, we're happy to respond to that. And yeah, so we'll give you just 1 minute to ask any other additional questions or anything like that, and then we'll split up and continue work. I was about to say get to work, but we've all been working.
Braden, while we wait to see if anyone else has questions or thoughts, I just wanted to throw out there and come on camera to say I will be at the NSEMSO meeting this next week. So if any of you happen to be there and you see me walking around looking a little lost, because this is my first meeting, please feel free to come up and introduce yourself. I would love to get the chance to meet with you and talk with you. So I'm really looking forward to that.
And for those who haven't met Melissa, she's essentially our new Mike, more or less. her role's a little different, but she's our fearless leader now. So definitely take a chance to meet her. Thanks so much for everybody's time, and never hesitate to reach out to your EDCTA. We're here to help, and we genuinely and truly appreciate all the hard work that is going into this project, and just keep it up. Let us know how we can help. Thanks, everybody.